Guys, and welcome back to the second half of Neurology for the Non-Neurologist on the lecture on interpreting neuroradiology. So we're going to pick up right where we left off last lecture, and we're going to go back straight into catheter-based angiography. Then we'll talk about CT perfusion testing, and then we're going to move on to the infamous brain MRI, which you're going to get a ton of on our service. Just a reminder, I put the slide back here, same one I showed at the end of the last video, comparing CTAs, the MRAs to catheter-based angiography. I'm not going to rehash everything we talked about with CTAs and MRAs. You can look at the last lecture for that. But I wanted to bring this up to remind you of the pros of catheter-based angiography, or DSA, which I'm going to refer to it as. And specifically, the DSA really gives us the best vessel imaging available, and also it allows us access to endovascular therapy. Again, at the cost of significant contrast exposure, and the fact that it's invasive and can have morbidity and mortality, but really is some great studies. So here's a couple pictures of vessels noted on DSA, both in the arterial and venous phase. And as you can see with this imaging, we're really able to delineate not only large branches of the cervical willis, but also the very small distal branches. And then we can use the same method with just delayed fluoroscopy to capture really beautiful images of the venous system of the brain. And again, you can just see very fine details you never catch on CTA and MRA. And then similarly, we can use DSA to identify several different pathologies, pathologies of the vessels at least. So on the left here, you can see a large AVM as the arterial system here is flowing into the sinuses, and so you can see a large AVM as it flows into the sinuses. Here you can see a really large ACOM aneurysm between the two ACAs. And then out here you can see a really great example of primary angiitis of the CNS. You see all these beads on a string and just very ratty looking vessels. This is something called primary angiitis of the CNS, or CNS vasculitis. But then, as we talked about, DSAs aren't just great for imaging vessels, it's also great for performing potential intervention. So just some of the potential procedures we can do include coiling of aneurysms, where small wires are fed into an aneurysm until they clot off, embolization of vascular malformations, and then actually we can do intraarterial injection of verapamil to evaluate for vasospasm, and that's because vasospasm should reverse with calcium channel blockers. Intracranial stenting was a practice that previously was gaining some traction, but more recent studies have shown intracranial stenting actually typically has very poor outcomes. So this is really only used as last resort. And then finally, thrombectomy has really revolutionized stroke care. By pulling a clot out in an acute stroke, you allow for revascularization, you can often save a penumbra, and you can really dramatically change patient outcomes. Here's a great picture of a proximal left MCA occlusion that was completely opened back up with thrombectomy. I talk a lot more about thrombectomies and their criteria in the acute stroke lecture, but it is important to understand their basic indications here. So currently thrombectomies are being limited to strokes where there's a large vessel occlusion, or LVO, typically of the MCA or ICA. It's one that is less than 24 hours old, and then it's something that has a favorable core perfusion mismatch as determined by CTP. So what the heck does that mean? So that's where our next imaging modality comes into place, the CT perfusion study. So we have a saying in stroke neurology that time is brain, but this really isn't always true. No two brains are alike, and while one stroke could be salvageable 23 hours after occlusion, another brain, perhaps in a person with poor collaterals, could be completely infarcted after just a couple hours. And so because of this, the CT perfusion study was developed to determine how much of a stroke bed was infarcted or core tissue, which is already dead, versus how much is tissue that is salvageable but at risk of dying, which is known as the penumbra. This is based on fancy physics metrics. They're cool, but they're not worth discussing. But we'll take these two values and we compare them in a ratio, and if they have a small core and a large penumbra, they're considered a favorable mismatch and they're good candidates for intervention. There's a lot to be saved. So this picture on the right is a great example of that. In the red, you can see the infarcted core, which is large, but it's clearly not as large as the penumbra, which is in green. And so this would represent a really favorable mismatch, and so thrombectomy was performed in this patient. And then on the right side, you can see an MRI performed later that shows that the stroke really ended up only involving tissue that had been dead prior to intervention. So only the core is involved, and pretty much the entire penumbra was saved. And it's pretty amazing. And we actually are seeing this more and more. And it's just a cool thing to be part of. And then the last thing I want you to understand about cerebral angiography is to know the basics of TICI scoring system, because this is something you're going to frequently hear discussed on our service. So TICI scoring system refers to how successful intervention was in revascularizing an occluded vessel. It's graded from 0 to 3. So as you can see here, 0 means that no perfusion was obtained. 1 means that only minimal reperfusion was obtained. And then 3 means that the vessel was completely reperfused. And then 2 stands for partial filling. So again, more than 1, less than 3. And then that's broken into 2A and 2B based on if it's less or more than half of the vascular distribution, which was restored. This is probably worth tucking away in your head. You're going to see it a lot on our neurology service, and we'll talk about it. And so it really helps you know if they had a successful thrombectomy or not. All right, take a quick breather, but not too long. It looks like Will is pretty excited to learn about MRIs, so she's ready when you are. Okay, so let's get into it. So we use MRI of the brain a lot in neurology. It's an excellent imaging modality, specifically because of its superiority to CT in terms of examination of details. When I explain it to patients, I tell them we're using it to get a high definition look at their brain, and that's essentially what it is. The level of detail that it helps you can be really helpful in picking up small lesions, anatomy, and a lot of stuff that can go missed on head CT. And specifically, it's helpful at picking up some small subcortical and brainstem lesions. Furthermore, the MRI has some special sequences that are really good at detecting certain things, including acute stroke, which we'll discuss here, that are just hard to see on CT. The drawbacks of MRI, of course, are that it's a slow test. It isn't the best in emergent situations. And then also it's non-compatible with metal implants. And like I said, we run into this issue a lot, mostly when we're trying to scan patients who have pacemakers. So when interpreting an MRI, you need to have a firm grasp on a couple different things. One, of course, being neuroanatomy, which I don't discuss here, but the other is just knowing what sequences to use and how to use them and when to use them. And so let's just start with the basics. So first, it's really important to understand the difference between T1 and T2. If you want, you can memorize or try to memorize this table, but I always found it easier to just remember that T1 basically appears normal. It always was helpful to me to just remember that the first scan, T1, appears normal. And by this, what I mean is that areas of gray matter, such as the basal ganglia, like down in here, the cortex, stuff like that, is gray. And then, contrarily, areas of white matter are white. So again, T1 is basically normal. If you remember that, then T2 is just the inverse. Things that are gray matter appears white, white matter appears gray. T2 flare then is the same sequence as T2, but the one thing you'll notice is that here the CSF is really white in T2 versus flare. We kind of take that out just because that really bright CSF can be kind of distracting. So what do we use these sequences for? Well, T1 is often considered the best sequence just for interpreting anatomy, likely because it appears normal. Like I said, gray is gray, white is white. So if you're working for just a purely structural process, I'd start with T1 imaging. T2 flare, on the other hand, is probably kind of our go-to sequence when doing a general screen for pathology. As I'll talk about in a second, there are certain sequences that highlight specific types of lesions better, but T2 flare demonstrates most types of CNS pathology, both acute and chronic. Right here is a great picture of some MS lesions seen on T2 flare. And so if I had to pick kind of one MRI sequence to just get a general idea of a brain's health, I'd probably start with T2 flare. A T2 without flare, on the other hand, is used less often. Again, like I said, mostly just because the bright CSF can be distracting, but T2 without flare is actually very helpful in picking up some very small lesions next to the CSF, typically in the posterior fossa. And this is because physics involved with creating a flare image can sometimes artificially remove these lesions. So here on the right is a great picture of a tiny dorsal midbrain stroke, which may have been tough to see on CT FLAIR. Other sequences that we frequently use on our service include DWI and ADC. So DWI, or diffusion weighted imaging, is a sequence that detects abnormalities of water motion and cellular swelling. So this means that it's excellent in the detection of acute stroke, and that's exactly what we use it for. So really within minutes, an acute stroke can demonstrate diffusion restriction, and this clearly helps us delineate a stroke bed, which may not be seen on CT. That said, don't forget that anything that disrupts water motion, including highly cellular tissues like tumors, can cause diffusion restriction, but we really only use DWI for acute stroke, but just know that's not the only thing that causes DWI changes. Another really important concept to understand about DWI sequencing is that it's prone to artifact known as T2 shine through, and this is because DWI sequence is loosely derived from T2, and so a really bright lesion on T2 can actually make the DWI appear bright, making you believe that an old lesion on T2 is actually an acute stroke, but it's just artifact. So to rule this out, we use ADC imaging, which you'll see here on the far right. So any lesion that truly has diffusion restriction, such as an acute stroke, is going to have a correlating dark spot on ADC. I always would remember that W in DWI stands for white, and D in ADC stands for dark. This picture is a great example of an acute stroke where we see bright white on DWI, correlating regions of darkness on ADC. If these ADC lesions were not present, we would just call this T2 shine through and say it was an artifact. I know that's complicated, but it's really important to understand. We use DWI and ADC very frequently. It's important to know what it is and know what is and isn't a stroke or an acute stroke. And then there's a lot of other MRI sequences out there. Many we really only use still for research purposes, but there's a couple of key ones I want to touch on that you'll see on neurology. So the first of these is gradient echo, or GRE, which may also be called susceptibility weighted scanning, or SWAN. GRE and SWAN have very subtle differences in how they're performed and obtained, but for our purposes, they're basically synonymous. A GRE or SWAN is your scan of choice for when you're trying to visualize either blood or minerals, such as calcium in the brain. For example, we'll use this test when we're attempting to see how much hemorrhagic conversion is present in a patient with a recent ischemic stroke. We also use it to look for microhemorrhages, like in this picture here. Remember, you still want to use a non-contrast head CT if you're trying to rule out an acute bleed. And this isn't what you want in an urgent setting, but these scans are helpful for delineating finer details. And then the last sequence in MRI that I'm going to talk about is post-contrast, which is performed with gadolinium contrast. I'm not going to belabor this because I touched on it already with CT, but remember that contrast helps to detect areas of breakdown of the blood-brain barrier. So specifically, this helps us classify and interpret things such as certain tumors, infections, abscesses, things like this. Ring-enhancing lesion here, toxo on the right, and then also acute demyelinating plaques in MS. While these are the same things that you would see on a contrast-enhancing CT, just remember that MRI is far superior just because of the detail it can show you. And so you really, if you're going to be looking for a contrasting lesion, just use an MRI rather than a head CT. And then last thing we're going to touch on just really briefly is how to use MRI to grade acuity of hemorrhage. Even though we use GRE and SWAN to detect hemorrhage, we actually use T1 and T2 to determine the acuity of them. This isn't something that I would memorize. You can always look it up, but there's a nifty and kind of absurd mnemonic out there. It's IB itty bitty baby doo doo, which is just absurd, but it is helpful. And in this mnemonic, you use the words to remember which color T1 is and which one T2 is, as you can see here in the chart. I being isointense, B being bright, D being dark. Again, I wouldn't memorize this, but it's just good to know this mnemonic and chart exists when you're posed with that question. And that's it. So let's knock out a couple solid review questions before you leave. So first question, a 33-year-old male undergoes a head CT which reveals a small hypodensity in the left frontal lobe. Which of the following could this represent? The sphenoid bone, a region of pneumocephalus, a calcified area of choroplexus, or a left frontal ICH? The answer here is B, a region of pneumocephalus. So all you need to know for this question is I'm asking for a hypodensity, and so you need to know which of these are hyperdensities, which will show up white on CT, and which are hypodensities, which show up dark. The only hypodensity listed here was air, which would be seen in pneumocephalus. Bone, calcium, blood are all hyperdensities. And then don't forget that CSF and ischemia are some of the other common hypodensities we'll see on head CT. Okay, next question. 68-year-old male with past medical history of hypertension, diabetes, and AFib presents with acute onset aphasia and right-sided weakness. He has normal kidney function. What imaging should be ordered stat? No multiple choice on this one, guys. It's got to be pretty reflexive. Good. So that's a non-contrast CT and CTA of both the head and neck. If the kidney function is poor or unknown, then the CTA becomes a risk-benefit discussion. But I'll talk more about that in the stroke lectures. But this is kind of the classic imaging that ER or we will perform in an acute stroke setting. All right, next one. So you're presenting to an overnight patient who was admitted for a stroke. You copied your HPI forward, which was written by the NSI, and in it you mentioned that your patient underwent thrombectomy with TICI 2A scoring. You're very intimidating attending asked you to explain what you meant by this. So did you mean A, that the thrombectomy was successful with partial but less than 50% reperfusion? B, that the thrombectomy is minimally successful? C, that the thrombectomy is successful with complete reperfusion? D, that the thrombectomy was unsuccessful? Or E, that it was successful with greater than 50% but not complete reperfusion? And the answer here is A, successful with partial but less than 50% reperfusion. So let's take another look at thrombectomy TICI grading scoring. Remember that 0 is no reperfusion, 1 is minimal, 3 is complete, and then 2 is partial reperfusion, which is broken into less than 50% of vascular distribution, or 2A, which we had here, and then more than 50%, which is 2B. By the way, did you guys know that French fries weren't actually first made in France? They were actually first cooked in Greece. Okay, I will see myself out. But before that, let's do one more set here of matching. We're going to pair lesions on the left with the sequence you want to choose to view it on the right, starting with any MS lesion. And any MS lesion can be picked up with D, T2 flare. And remember that flare is a great general pathology screening sequence. So how then do you delineate if the MS lesion is new? And that's with B, T1 post-contrast. Remember that contrast helps us detect active disruption of the blood-brain barrier, which we see in active demyelination. And this is why you'll hear us actually say that a contrast-enhancing lesion is a sign of active MS. Okay, what about any stroke? Again, this is going to be D, T2 flare. If we're really looking for just stroke in general, chronic, subacute, fairly acute, T2 flare is great to pick it up. It doesn't capture hyperacute though, which we'll talk about in a second. What if though you're looking for a smaller old stroke that you suspect is in the dorsal midbrain, but you really can't see on traditional imaging? Well, this is C, T2 flare, or T2 without flare, and this is when it comes into play. Again, we rarely use this, but in this situation, when you suspect a small lesion in the brainstem that may have been artificially reduced by flare, this is a good time to use it. Okay, next one. How would you look then for hyperacute or acute strokes? And this one's important to know. Good. It's E. So you have DWI, and then remember that any DWI hyperintensity must have a correlating ADC hypointensity to show that it's just not artificial T2 shine through. All right, the next one. What if you're looking for a tumor? So this one's a little tricky, but probably you would use both T2 flare and T1 post-contrast. Again, T2 flare is your kind of general pathology screening, so it should demonstrate the tumor. But certain tumors do have characteristic contrast enhancement, which really help us delineate their type. Okay, next one. You're looking for microhemorrhages? Good. This is F, which is GRE or SWAN, and these are the two scans that we use to look for blood. So they're perfect for things like microhemorrhages. And finally, last one, abscess. And just like in tumor, this is both D T2 flare and B T1 post contrast. Infectious processes should have flare changes, but they do almost always enhance. So if you're not sure if the lesion you're seeing is an abscess or not, I'd just check a post contrast imaging, and you should see it light up. And that's it, guys. There's a ton to know about neuroradiology. It takes years to understand all the nuances of it. But hopefully we covered a lot of the important topics that you'll see on our service and when you're taking care of neurologic patients that should give you a solid baseline for tackling this going forward. That's it for now. I'll see you guys on the next Neurology for the Non-Neurologist lecture.